Good afternoon. Thank you for attending the first leg of activities for the World TB Day celebration. We will be focusing on drug-resistant TB, which is now gaining prevalence in the community, further adding to the TB burden of disease. I am Dr. Clarissa MDRTB, one of the PMDT STC physicians. The Stop TB Partnership estimated around 591,000 people who developed TB in 2020. Among them, 773,000 were children. Although with these estimates, 43% were identified as missing from the TB notification. Also, in 2020, there was a drop of almost 80% in the number of people who were diagnosed with both HIV, TB, and back infection. There was no available estimates for those who develop drug-resistant TB, as it is more difficult to diagnose, treat, and cure. There was an increase of 7% in people who died because of TB at 31,000 cases, bringing TB as the second cause of mortality among communicable, maternal, neonatal, and nutritional diseases. DOH had around 257,000 new and relapsed TB cases identified in 2020, with about 150,000 fewer people with TB detected by health systems in the Philippines. This reflects a gap of 57% between estimated and notified cases. This was mainly because of the disruption of TB services in 2020 due to the COVID-19 pandemic. The 2021 Philippines National Tuberculosis Report showed the treatment success rate in 2018 targeted at 71%, only at 67.4, which is way below the treatment success rate targeted for that year. The 2020 NTP MOP, the 6th edition, which is the latest one that we are using right now, provided a treatment success rate of more than 85% for DRTB, which means to say we have to be more adamant, vigilant, more aggressive in other case finding for drug-resistant TB. So the objective of this afternoon is to provide an overview of the DRTB status in the Philippines. Second, to explore areas for active case finding of DRTB cases. Third, enumerate the required laboratory tests to determine treatment regimen and subsequent tests for treatment monitoring. Fourth, to present a different treatment regimen in DRTB case holding. Fifth, discuss the adverse drug reactions and the management. Sixth, to identify treatment outcomes and post-treatment monitoring. The content of this afternoon's lectures will be mostly lifted from the Manual of Procedures, 6th edition, released in 2020. Other sources will be identified respectively. This is the systematic screening algorithm for tuberculosis. Of course, we need to ask for the following signs and symptoms, which lasted for 2 weeks: cough, unexplained fever, unexplained weight loss, and night sweats. If these symptoms are present in our patient, if it's yes, then we have to consider them with presumptive TB. Otherwise, the chest X-ray is indicated. If the finding is suggestive of TB, consider the patient with presumptive tuberculosis. If the chest X-ray finding is not suggestive of TB, we consider other diseases. For those patients with presumptive TB, we need to request expert MTB RIF test, or what we commonly know as the gene expert. If patients do not present with symptoms, we have to identify the following TB risk factors. If they have been contacts of TB patients, if they were ever treated for TB or with a previous history of TB treatment, People living with HIV, screening by both X-ray and symptoms should be done at the time of diagnosis of HIV/AIDS and annually thereafter. Those who are elderly are also considered with TB risk factors, diabetics, smokers, healthcare workers, urban and rural poor, the indigents, and those with other immune suppressive medical conditions like silicosis, solid organ transplant, connective tissue or autoimmune disorder, end-stage renal disease, chronic corticosteroid use, alcoholics or substance abusers, chemotherapy, and other forms of medical treatment for cancer. So when do we consider presumptive drug-resistant TB? These are questions that we need to ask during history taking. If the patient had a previous history of TB, for those who are close contacts of known DRTB cases, and those who are non-converters of the DSTB regimen. For close contacts of known DRTB cases, we need to ask if the person they have been living with who are treated for TB are under the drug-sensitive regimen or the common TB dots in the health centers, or with a DRTB case, which lasts longer than our 6-month regimen for DSTB. Non-converters of DSTB are those who remain positive despite the initiation of treatment for DSTB. So say, for example, before the end of the intensive phase for a drug-sensitive TB regimen, and the patient still has a positive smear for AFB staining, the person may be a non-converter for DSTB and is considered presumptive for DRTB. So this is a comparison of procedures for screening for DSTB and DRTB household contacts. For DRTB contacts, gene expert is required, and monitoring for follow-up would be every 6 months for the next 2 years. You have to take note that TB preventive treatment is not recommended for DRTB contacts when TB is ruled out. The diagnosis of rifampicin-resistant TB is done through a rapid diagnostic test, expert MTB-RIF, or our gene expert. And this is a primary test that we use for TB, PTB, and EPTB in adults and children. All presumptive TB patients who are at risk for MDRTB shall be referred for such testing. In the absence of an expert MTB-RIF testing, smear microscopy, or the DSSM, or the loop-mediated isothermal amplification, TB lamp, can be alternative diagnostic tests. A regional TB medical advisory committee is established per region, who will also provide clinical expertise and guidance in the diagnosis of clinically diagnosed DRTB cases and the management of difficult DSTB and DRTB. The sputum is a primary specimen submitted for expert RIF MTB. However, extrapulmonary specimens may be submitted are the following. Respiratory specimens other than sputum could be tracheal aspirates, endotracheal aspirate, bronchial washing, bronchial alveolar lavage fluid, and nasopharyngeal aspirate. For non-respiratory specimen, gastric aspirate, cerebrospinal fluid, other fluid aspirates, and body fluids like the peritoneal and synovial fluids can also be submitted. Tissues and fine needle aspiration biopsy specimen immersed in 1 to 4 ml of normal saline solution may be screened with expert RIF MTB testing. Currently, blood, urine, and stools are not accepted specimens. This is very important for you to take note that there are other specimens that can be submitted. So for those considering extrapulmonary TB, like say for example, joints and in the bones and joints. So synovial fluid or the tissues taken during biopsy can be submitted for testing. This is how we interpret the results. If the notation is T, it means Mycobacterium tuberculosis detected, rifampicin resistance not detected. For RR, it's MTB detected, rifampicin resistance detected. TI, if MTB is detected but rifampicin resistance is indeterminate. N, if MTB is not detected. And for I, if there is no result, the result is invalid or there was an error during processing. So what do we do after the diagnosis? For those with Mycobacterium tuberculosis detected but rifampicin resistance not detected, we classify them as having drug-susceptible TB disease and refer them to the TB clinic at the OPD or at the local health center for them to be enrolled in the NTP program. Medications are free. Treatment lasts for 6 months for pulmonary and extrapulmonary TB, but may last up to 9 to 12 months if the patient has extrapulmonary TB of the CNS, joints, and the bones. If the notation is RR, for MDRTB high-risk groups like those contacts of DRTB patients, those with previous TB treatment, and for those who are non-converters in their DSTB regimen, we will be classifying them as drug-resistant TB. But for those who are at low risk or new TB cases, they will be classified as bacteriologically confirmed TB, but we need to recollect a fresh sputum sample and repeat the expert MTB test. And then we follow the second result. So say, for example, a patient with no history of TB contact, no history of TB treatment, and are non-converters, but will have a positive, will have an RR result, MTB detected, rifampicin resistance detected, we will be repeating the gene expert. And if the second result of the gene expert will be T, or rifampicin resistance not detected, the patient will be classified as to the second result. For TI and I, again, we recollect a fresh sputum sample, repeat the expert MTB test, and follow the second test result for the treatment decision. So what are the different classifications of drug-resistant TB? First, we have the bacteriologically confirmed rifampicin-resistant TB. These are patients with positive MTB using the gene expert with known resistance to rifampicin. Bacteriologically confirmed multi-drug resistant TB are those positive for the MTB complex with known resistance to at least both isoniazid and rifampicin. For bacteriologically confirmed extensively drug-resistant TB, or the TB XDR, these are patients positive for MTB complex with resistance to any fluoroquinolones and to at least one second-line injectable drug like the amikacin and streptomycin, in addition to multi-drug resistance, namely isoniazid and rifampicin. Clinically diagnosed multi-drug resistant TB can be any of the following: those negative for MTB complex, those with specimens showing other resistance patterns, laboratory diagnoses are not done due to specified conditions, or the diagnosis showing both resistance to both isoniazid and rifampicin from a non-NTP recognized laboratory. If these are the presentations, but with clinical deterioration and/or radiographic findings consistent with active TB, or treatment has been started with empiric antibiotics but has showed no response, and when presented to the TB MAC has been decided for treatment under the programmatic management of drug-resistant TB, they can be classified as clinically diagnosed MDRTB. Other drug-resistant TB classifications are the following: monoresistant TB with resistance to one first-line anti-TB drug except rifampicin, so any of the three first-line drugs. Polydrug-resistant TB, which shows resistance to more than one first-line anti-TB drug other than both isoniazid and rifampicin. So this can either be ethambutol or pyrazinamide. And third, other DRTB is the serious adverse drug reaction to rifampicin. So the patient on drug challenge during with the first-line anti-TB drugs, so the 4-drug regimen for DSTB, and during treatment challenge, which means giving the individual drugs at a certain time and observing them for adverse drug reaction, has serious side adverse drug reaction to rifampicin, the patient can be enrolled under programmatic management as other DRTB indicating serious adverse drug reaction to rifampicin. So of these three, whether bacteriologically confirmed or clinically diagnosed, they can be enrolled for under the PMDT, but this has to be decided by the TB MAC as having TB disease. Under the 2020 NTP MOP, MDRTB and RRTB treatment shall be started within 7 days from the diagnosis. Although 7 days is explicitly indicated in the manual of procedures, the subsequent lecture, or the following lecture on baseline laboratories required before initiation of treatment, will explain why there could be a delay in the initiation of treatment for MDRTB. With that, I end the overview, and another staff from the PMDT STC will be doing the subsequent sessions. Thank you very much for your attention.